Hi, okay, today we're going to cover Chapter 5 in our ICD-10 guidelines. So I'm going to go ahead and share my screen. Let's see. Okay. Chapter 5 is our, as you can see here, is our mental, behavioral, and neurodevelopmental disorders. And the code range for this section is F01 through F99. Just going to make it a little bit bigger. Okay, so again, these are in the front of each of your chapters. These guidelines are in the front of each of your chapters. So as you're going through your ICD-10 book, you'll see this exact same guideline and layout with these examples in front of each chapter. So this one will be in front of Chapter 5. So the chapter-specific guidelines are from the ICD-10 official guidelines for coding and reporting, and they've been provided below. Along with these guidelines are coding examples, and that's what's contained in these shading boxes. They have been developed to help illustrate the coding and any sequencing guidance found in these guidelines. So there's more guidelines sometimes than examples, but this is a great tool to get to know. So today, we're just going to cover one chapter. We'll cover this one, Chapter 5, and we'll move on from there. So our first guideline is associated with pain disorders related to psychological factors. So we'd assign code F45.41 for pain that is exclusively related to a psychological disorder. And we have an excludes one note under category G89. A code from category G89 should never be assigned with code F45.41. And here's our example. Perceived abdominal pain determined to be persistent somatoform pain disorder. F45.41, pain disorder exclusively related to psychological factors. And our rationale here is the pain was diagnosed as being exclusively psychological, therefore no code from category G89. And if you remember, code G89 is pain not elsewhere classified. So it's in the section for pain. You can flip over and look up code G89 if you'd like more information about it. Code 45.42, pain disorders with related psychological factors, should be used with a code from category G89, pain not elsewhere classified, if there is documentation of a psychological component for a patient with acute or chronic pain. And there is another section we could see, specifically the pain section, which is coming up in another video. Okay, so our next guideline, mental and behavioral disorders due to psychoactive substance use. So we have in remission, selection of codes for in remission for categories F10 through F19, mental and behavioral disorders due to a psychoactive substance use. Categories F10 through F19 with -.21 in the code description requires the provider's clinical judgment. The appropriate codes for in remission are assigned only on the basis of the provider documentation as defined in the official guidelines for coding and reporting. So in this example that they give us, we see medical history, opioid dependence and remission. We would code that to the F11.21, opioid dependence and remission. And our rationale is the in remission codes are assigned when the provider documents the remission. And so if the provider didn't document the remission, we would just code to the unspecified opioid dependence. There's different codes around that. If you want to just take a moment and flip to F11.21, I can show you. So F11, if you go first to the category block F11, the opioid-related disorders, you'll see underneath category F11 all the different options that we have. So in the green text, that's abuse in the important parts of that code description. So right under opioid-related disorders, F11, you see F11.1, that's opioid abuse. If you go down further, you can see abuse with intoxication, abuse uncomplicated, abuse with delirium. If you go down even further to what we were looking at, which was opioid dependence, we see F11.2, opioid dependence. As you can see right under the code description, there's an excludes one note, opioid abuse and opioid use. So this is probably a good time to go over if abuse is documented, we would never code abuse with dependence. Or if dependence was documented and abuse was documented, we would only code the abuse. But you can see the different code descriptions for depending on whether they're in remission, whether they're intoxicated currently, or whether it's unspecified, which is uncomplicated. That's how we would select our code. And if it is documented in remission, then we would use the remission code, but that has to be determined by the provider. So moving on, psychoactive substance use, abuse, and dependence. And so psychoactive substance use, that's just your alcohol, your drug use, cannabis use. That's what they mean by psychoactive substance. When a provider documentation refers to use, abuse, and dependence of the same substance, so this is kind of what we just went over, alcohol, opioid, cannabis, or any of the other drugs, only one code should be assigned to identify the pattern of use based on the following hierarchy. If both use and abuse are documented, assign only the code for the abuse. If both abuse and dependence are documented, assign only the code for dependence. If use, abuse, and dependence are all documented, assign only the code for the dependence. If both use and dependence are documented, assign only the code for dependence. So you can see that dependence trumps everything else. And then abuse trumps use. So it's a hierarchy. This is important. So just make sure you highlight this guideline so you can refer to it. Because you might have a question on your exam that documents both alcohol use and alcohol dependence, and one of your answer options might have both of those codes in it, but when it should only have the dependence code. So just make sure you know where this guideline is. It's in the beginning of your book and also in the beginning of chapter 5. So moving on, we have a couple examples just illustrating that. History and physical notes, cannabis dependence. Progress note says cannabis abuse. In this situation, we're going to go ahead and code F12.20, cannabis dependence uncomplicated. And our rationale is, in the hierarchy, the dependence code is used if both abuse and dependence are documented. So we just learned that dependence trumps everything. Discharge summary says cocaine abuse. Progress notes list cocaine use. Here, again, we would implement that hierarchy and we would code F14.10, cocaine abuse uncomplicated. And our rationale is, in the hierarchy, the abuse code is used if both abuse and use are documented. So that's an important guideline for this section. We're going to move on to psychoactive substance use. As with all other diagnoses, the codes for psychoactive substance use, and that's our code range, should only be assigned based on provider documentation and when they meet the definition of a reportable diagnosis. And that's in section 3, reporting additional diagnosis of our ICD-10 guidelines, so you can go back and reference that. The codes are to be used only when the psychoactive substance use is associated with a mental or behavioral disorder, and as such relationship is documented by the provider. So the ED reports that a 27-year-old female tripped and broke her right ankle. Her friends reported that they were drinking and dancing at the nightclub. So the codes assigned here, we see S82.891A. That's other fracture of right lower leg, initial encounter for closed fracture. And we haven't really got into our fractures yet. They're the S section, but we will soon. Then we have W01.0XXA, fall on the same level from slipping, tripping, or stumbling, initial encounter. And then we have our place of occurrence code, our Y92.252, music hall as the place of occurrence of the external cause, and our Y93.41, and the activity is dancing. So these are, we're getting into our external cause codes. Sometimes when you see those funny pictures of like bitten by orca, second occurrence, this is the same section that those codes are found in, and we'll get to those at the end. Most coding jobs that you might apply for or be interested in don't all do this external cause coding. Only certain types of coding agencies and employers are doing external cause coding. So the explanation, the rationale behind this is, note that no code was added for alcohol use or abuse. Unless it's specifically associated with a diagnosis by a provider, by the provider documentation, and it meets the definition of a reportable diagnosis, it is not assigned. However, if the documentation from the provider stated, the patient tripped, fell, and fractured her right ankle while dancing due to her high elevated blood alcohol, consistent with her ongoing alcohol abuse, the following code would be added, F10.10, alcohol abuse uncomplicated. So basically what that is telling us is what we've gone over a few times already. If it's not documented, we don't code it. We don't create it by what we think the documentation means. If it's not documented by the provider as a coder, we would never code it. Even if we think we know exactly what it is, if it's not documented by the provider, we would not code it. So that's the end of Chapter 5. And next, we will go over Chapter 6, diseases of the nervous system.